Welcome back to the Deep Dive. Today we are getting into a skin condition that affects millions, but is often misunderstood. We're talking about Erythematotelangiectatic Rosacea.
Well, ETR.
Yeah.
It's much easier to say.
Definitely. You might know it as vascular rosacea, or more simply, rosacea type 1.
Right. And ETR is really defined by what you can see. We're talking about that persistent facial redness, what we call erythema, and those tiny visible blood vessels.
And that's our mission for this deep dive. We really want to unpack what makes type 1 so specific. We're going to get into the causes, which are this, complex mix of genetics and environment.
And then the management. We'll look at the key medical treatments and lifestyle changes that can actually make a difference. This isn't a condition you can just ignore.
Not at all. It requires really specialized care.
Absolutely. And it all starts with the diagnosis, right? The focus is on that persistent redness and those little dilated blood vessels, usually right on the central part of the face.
Cheeks, nose, forehead.
Exactly. And at its core, you need to understand it's a vascular issue. The blood vessels they're hypersensitive, they dilate way too easily because of this combination of genetic predisposition and, well, external triggers.
Okay, so let's unpack that classification. Why is it called type 1? I mean, what does that number actually signify?
It's designated type 1 because it's the most common form of rosacea, and it's often the very first way the condition presents itself. The diagnosis really hinges on what you can see, or more importantly, what you can't see.
So what are the two visual hallmarks then? The things that tell you, okay, this is definitely ETR.
So first is what we call persistent facial erythema. This isn't just a temporary blush. It's a constant background redness. It can make someone look like they're always flushed or maybe have a mild sunburn.
Right.
And second, visible blood vessels. The technical term is telangiectasia. They look like these tiny, fine red or sometimes purplish lines right under the skin.
So if the visual symptoms define the type, that leads to a really important point, telling type 1 apart from type 2. The big difference, as I understand it, is the lack of acne-like bumps.
Precisely. That is the crucial distinction. If you see that persistent redness plus bumps and papules and pustules, then you're looking at papillopustular rosacea, which is type 2.
And knowing that difference is key.
It's vital. For someone with type 1, knowing you only have the vascular component helps with early detection and really dictates the whole treatment plan. If you treat type 1 early, focusing on the blood vessels and inflammation, you have a much better chance of preventing it from progressing.
And it's not just about what it looks like. There's real discomfort that comes with ETR, isn't there?
Absolutely. The sources are clear that ETR patients often have these really frequent, intense episodes of flushing, a sudden heat and redness that just rushes to the face.
And that's more common in type 1 than type 2.
Much more common. And on top of that, there's often a constant burning or stinging sensation in those red areas. And the skin just becomes hypersensitive to, well, almost everything. Wind, sun, certain skincare products.
That makes sense. Now, since facial redness can be a symptom of other things, how do we separate ETR from, say, dermatitis or eczema? What's the core difference?
Yeah, this is where it gets really interesting. The mechanism is completely different. ETR is a primary vascular issue. It's about overreactive blood vessels.
Okay.
Eczema or dermatitis, on the other hand, is usually driven by an overactive immune response or an allergic reaction. That's why you get those dry, scaly, super itchy patches that can even blister. The look is different because the root cause is different.
But you mentioned there's a connection between them, a common thread.
Yes, and that common link is skin barrier dysfunction. So important. A compromised skin barrier is a huge problem in both conditions.
So even if the cause is different, the result is a weakened defense system.
Exactly. When that outer protective layer is weak, you lose more water, your skin gets more sensitive, and it lets external irritants, pollution, harsh ingredients, you name it, get in more easily. This triggers inflammation, which for ETR shows up as redness, and for eczema as dryness and scales. Repairing that barrier is just fundamental.
That makes perfect sense. Okay, let's move on to triggers. We know genetics loads the gun, so to speak, but what actually pulls the trigger for these flare-ups?
Right, so let's start with environmental factors, things that are kind of hard to avoid. The absolute #1 trigger is sun exposure.
I was going to guess that.
Yeah. UV radiation makes the vessels dilate, and it damages collagen, which makes the whole situation worse over time. Then you have things like extreme temperature changes.
Like walking into a warm building on a cold day.
That's a classic one. Or even just intense wind.
Those are the external assaults. What about the internal triggers, the things we eat or even feel?
Internally, it's fascinating because the triggers are so varied, but they all share a common pathway. Anything that raises your core body temperature or your blood pressure is a potential problem.
Like stress.
Emotional stress is huge. That rush of hormones you get from anxiety or anger, they act as powerful vasodilators, so you get an immediate flush.
And what about diet? What should you be really careful with?
The big ones are things that create internal heat. So very hot beverages, it's often the temperature of the coffee or tea, not just the caffeine.
Oh, interesting.
And of course, spicy foods. Capsaicin, the compound in chili peppers, directly triggers nerve endings that cause flushing.
Let's focus in on alcohol. It's probably the most well-known trigger, and there's a lot of stigma around it. What's the science behind why it aggravates ETR so much?
Alcohol is a major issue because it attacks the problem from multiple angles. The most immediate effect is vasodilation. It just causes the blood vessels in your skin to expand right away.
Making everything redder.
Instantly redder and making those little telangiectasias more visible. It's really the worst case scenario for ETR skin.
And we always hear about red wine being the main culprit. Is there a scientific reason for that, or is it just an old wives' tale?
No, there's a very clear scientific basis for it. Red wine is like a triple threat. You have the alcohol, of course, but it also contains high levels of histamines and tannins.
Okay, what do they do?
Well, histamines trigger an immediate inflammatory, almost allergic type response in the body. And tannins can be an irritant as well. That combination makes red wine uniquely effective at causing a flare-up compared to something like a clear spirit.
So it's not just a fleeting blush. The effects are more systemic, especially when we think about that skin barrier you mentioned earlier.
Absolutely. And this is a point worth pausing on. Alcohol is a diuretic, right? It makes you dehydrated. Dehydrated skin means a collapsed barrier function.
So the skin's defenses are down.
Completely down. A weak barrier makes your skin more reactive to every single other trigger. So regular alcohol use is basically impairing your skin's ability to protect itself, which just amplifies every single symptom of type 1 rosacea.
Okay, so given this extreme sensitivity and this huge range of triggers, how is ETR actually managed? What are the main strategies?
It's really a two-pronged approach. You need medical treatments to control the symptoms, and you have to combine that with just aggressive, meticulous trigger avoidance and barrier-repairing skincare.
Let's start with the medical side. For a condition that's all about redness, what are the go-to pharmaceuticals?
For that immediate visible redness, there's a specific topical called brimonidine tartrate gel. It works as a vasoconstrictor.
Meaning it shrinks the blood vessels.
It literally shrinks them temporarily. It can give you a really quick, visible reduction in redness that can last for several hours.
That must be a huge psychological relief to have a temporary fix like that. But what about managing it long-term?
For long-term inflammation control, dermatologists often use topicals like metronidazole gel or azelaic acid. But the conversation gets really interesting when we talk about oral medications.
Right, the antibiotics. This is what I wanted to ask about. Why are antibiotics prescribed for something that isn't a bacterial infection, especially in type 1, where there aren't any pustules?
This is such a critical point. Low-dose antibiotics, like doxycycline, are not being used for their antibiotic properties here. They're being used for their powerful anti-inflammatory effects.
How does that work?
At these very low submicrobial doses, they don't kill bacteria. Instead, they modulate the body's inflammatory pathways. They basically calm down that internal heat that fuels the redness and sensitivity of ETR without the risk of creating antibiotic resistance.
That's a fascinating use of a common drug. But what about the vessels that are already there, the telangiectasia? Creams and pills aren't going to make those disappear, are they?
No, for those permanent visible blood vessels, you generally have to turn to procedures. Vascular targeting treatments like pulse dye laser PDL or intense pulse light IPL are really the gold standard.
They do what the medication can't.
Exactly. They address the damage that's already been done.
How do they actually work? How do they get rid of those tiny capillaries?
It's a principle called selective photothermolysis. Essentially, the laser or light emits a wavelength that is specifically absorbed by the hemoglobin, the red pigment inside the blood vessels.
Okay.
When the hemoglobin absorbs that energy, it converts to heat. That heat collapses the vessel wall, and the body just slowly reabsorbs the destroyed vessel over time without damaging the skin around it.
And is that a one-and-done kind of treatment?
Oh, not at all. It usually takes a series of sessions, maybe 3 to 5 spaced weeks apart. And because rosacea is chronic, you often need maintenance sessions every year or so. It's a big commitment, but for many type 1 patients, it's the most effective way to clear those visible signs.
Let's shift to the daily routine. We know harsh ingredients are a huge trigger. So let's talk about alcohol and skincare, because this can be so confusing.
It is incredibly confusing because alcohol on an ingredient list can mean very different things. You have to know the difference between the irritants and the helpers.
Okay, let's start with the bad guys, the ones to avoid.
You want to rigorously avoid the short chain or drying alcohols. That's things like ethanol, denatured alcohol, or isopropyl
The
alcohol.
ones that give you that clean feeling.
Right, but what they're actually doing is stripping your skin's natural oils and destroying that protective barrier. For ETR patients, they cause immediate burning, stinging, and flushing. They're a disaster.
So what are the good alcohols? It sounds like a contradiction.
They're called fatty alcohols. You'll see them listed as cetyl alcohol or behanol alcohol. These are completely different. There are large molecules that are waxy solids. They're used as emollients.
So they add moisture instead of taking it away.
Exactly. They lock in moisture, they strengthen the barrier, and they give creams that smooth, soothing texture without any irritation. They're your friend.
So if you're checking an ingredient list, cetyl and behanol are good, isopropyl and ethanol are bad. Got it. What else is essential for that daily routine?
Non-negotiable is daily broad-spectrum SPF 30 or higher, ideally a mineral sunscreen with zinc oxide or titanium dioxide, as they tend to be less irritating.
And the rest of the routine?
Just gentle. Everything has to be gentle and focused on barrier repair. Look for ingredients like ceramides and niacinamide.
And you mentioned a couple of really specific ingredients that are great for calming down flare-ups.
Yes, the sources pointed to a couple of interesting ones. Moisturizers with Manuka honey were noted for its unique anti-inflammatory properties. And even more targeted is something called hypochlorous acid spray.
What's that?
It's a compound that our own white blood cells naturally produce. And when you spray it on the skin, it has this potent anti-inflammatory effect. It can really help calm down irritation during a bad flare-up.
So to wrap up, we've covered ETR, or type 1 rosacea, defined by that persistent redness and visible vessels. We've talked about the genetics, the triggers from stress to spicy food, and the treatments, from specialized topicals to high-tech lasers.
I think the big takeaway is that managing ETR is all about controlling two things: chronic inflammation and that hyperreactivity of your blood vessels. And both of those problems are made so much worse by a compromised skin barrier.
So early intervention, trigger avoidance, and gentle care are critical.
That's the whole game, really.
Absolutely. And that brings us back to those internal triggers. Since we know ETR is so closely tied to things like emotional stress, and type 1 patients get more of that flushing than type 2 patients, here's a final thought for you to consider. How much more effective could all these physical treatments, the creams, the lasers, be if they were combined with dedicated, proven stress reduction techniques? Things like mindfulness or cognitive behavioral therapy, designed to calm the nervous system and maybe, just maybe, reduce the frequency of those really debilitating stress-induced flares. Something to think about as you refine your own strategy.